What it means to be both a lifelong learner and a leader in our field. Dr. Paul Salamh is a recognized expert in orthopedic research, particularly in shoulder-related conditions, and currently serves as a director of research for the Doctor of Physical Therapy program at Tufts University School of Medicine in Phoenix, Arizona. With a clinical background rooted in elite sports medicine, a PhD in shoulder research, and deep involvement in both admissions and education reform, Paul brings a unique blend of academic rigor and real-world relevance. What sets him apart is not just what he's achieved, but how he continues to serve, mentor, and evolve. In this conversation, we dive into his journey from the clinic to the classroom, explore his views on the hybrid DPT model, and unpack what it really takes to stay sharp, stay relevant, and stay humble in the profession. If you're an educator, clinician, or student wondering how to make a lasting impact, this one's for you.
I'm an emotional kind of heart kind of guy, and so I feel like those connections can be lost. From an AI perspective, I think what we have the potential to miss out on is the learning that happens through processes that we allow AI to do.
We're integrating AI machines from Switzerland, and we'll be one of the first in North America, and it's just going to give us more data to know if we're on the right track.
I think if I had to point out a few, would be kindness, humility, not being afraid to see yourself fail and let other people know about your failures and your struggles, and being vulnerable. I think vulnerability is a huge thing.
Ladies and gentlemen, Dr. Paul Salamh. Welcome, Paul.
Thanks, Tom. Appreciate you having me on.
Yeah. So I just want to initially start, what initially drew you into the world of physical therapy and what keeps you here all these years?
Yeah, kind of an unusual answer to that question. Like a lot of folks, I had shoulder injuries and surgery and rehab when I was in high school as a pitcher. But my initial draw wasn't to PT. I didn't even want to go to college when I was a senior in high school. I wanted to study business. I didn't even, is when I was forced to go to college. And then I decided I wanted to do something I was interested in, and it was physical activity and sort of fitness. And my parents were like, well, why don't you try physical therapy? I didn't even know what physical therapy was, but they kind of drove me in that direction. Neither of them had ever gone to college. No one in my family ever had, so they had no idea what that meant. And so I got into studying exercise physiology at a different university than when I was studying business. And then one thing led to another. And before I knew it, I was in PT school and fell in love with education and research along the way. And so kind of a different pathway into the field, but I'm glad I got pushed there, and I'm glad I am where I am.
Yeah. But you before academia, before you settled into that, you worked in clinic, correct? For 10 years or
Correct.
so?
Yeah.
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 What did that chapter teach you about patient care and professional fulfillment that you were able to carry into kind of academia?
A lot. Honestly, I think initially as a clinician, I kind of got into a routine. And I don't want to say a rut, but I was practicing sort of the same way over and over and over again. And thankfully kind of began to learn some of the differences and nuances from mentors. And I think that's the biggest thing for me is in clinical practice is having a good mentor, a good set of mentors to keep you grounded and help you kind of direct your clinical pathway, if you will, as a clinician, because it's easy to get burnout. It's easy to continue to practice the same way you learned when you were in school. And you and I both know that, things evolve, patients change, presentations change, evidence changes. And so keeping up with all that is a challenge. And the first part of that challenge is recognizing that you may not be doing that to the best of your abilities, and having someone hold you accountable in different capacities, I think is important, but challenging for new clinicians.
Yeah. So what kind of clinical setting, like how many patients per hour were you seeing in that clinical setting? Just to kind of get an idea of what, kind of situation or context you were working in that kind of started to lead you into that burnout phase or that dissatisfaction phase that you wanted to shift over into the academic side of things.
Yeah, so I came out of school initially and started working at Southeastern Orthopedics, which was a sports medicine and shoulder um, clinic. So we
Mhm.
saw a lot of individuals, mainly individuals with shoulder conditions. And so,
Yeah.
my passion for the shoulder was already sort of kindled in school, and then
Yeah.
certainly came across that line there. And I worked very closely with an orthopedic surgeon. Um, and he helped me develop a lot of different things outside of my PT training to
Yep.
understand sort of that aspect of things. So that was really cool. I was seeing patients, initial evals for an hour, follow-ups 45 minutes. So it was a
Oh,
really
that's good.
great opportunity, and sort of had free reign to, pick and choose what that looked like for me, which is unusual even
Yeah.
today and even back then in those standards. So I was very fortunate to have that. I think where I kind of um, began to get a little stagnant was because I was seeing so many individuals with shoulder conditions.
Mhm.
It became very easy for me to begin to see patterns maybe a little bit more quickly than I ought to,
Yep.
and sort of develop more of that pattern recognition thought process too early. Sort of I guess my ability to do what was appropriate maybe outpaced my actual ability,
Right.
if you will. And so I had initially started working on my PhD about 2 years into clinical practice. So I knew coming out of PT school there was some additional training I was interested in. I just didn't know what that looked like.
Right.
And through the help of some mentors, I was able to identify sort of a PhD and doing research, and so that kind of blended well together into to taking me to the next part of my journey.
What would you say has changed from your perspective of treating shoulders because you had, you know, specializing kind of early right out of school and treating shoulders and getting to, good results. Now, I don't know if it's, assessment and then protocols that are kind of tacked on the back end. What's changed? How would you treat now versus then? Has anything changed from your perspective of, let's just say, treating shoulders, right?
Yeah, I would say almost everything's changed for me, to
Yeah.
be honest with you. If you took me 10 years ago out of school and how I was trained, and I was trained by, some of the best orthopedic physios in the, at least in my opinion,
Yeah.
Chad Cook and Eric Hegedus taught me orthopedics. And so from a shoulder standpoint and from a manual therapy standpoint, and, I was getting top-notch education, and I think they would be pleased to know that I wouldn't, be practicing the same way they taught me, because all of our ways have evolved, right?
Yeah.
We've all developed and understood different things. So, you know, for me, I think the biggest thing is how I approach, I think as we age in our clinical development, we spend more time in the subjective and less in the objective, at least for me. I
Yeah.
spend more time with my mouth shut and my ears opening, listening to what matters to the patient, listening about their healthcare journey, where they started their healthcare journey, where they are now, who they've seen before, what imaging they have done, what's their narrative and what's their current understanding of what's going on with their shoulder, and what they think needs to happen in order for them to get better. I think early on in my career, I was acting more like a detective. I wanted to ask all the questions that I wanted to check off my list. I wanted to gather all the information, and then I wanted to do what I thought was best for
Right.
the patient, instead of gathering all the information and having a shared conversation with the patient at the end of it, saying, okay, this is what I hear you saying. Is that accurate? Anything you'd like to add? Anything I didn't get correct? Here are what I see as potential options for you moving forward,
Mhm.
with no treatment always being an option. What do you think is the most appropriate course of action for you? And let's have
Right.
a discussion about that.
Sure.
I think that's totally different than what I thought initially coming out of PT school. Like I said, I was that detective, and then at the end of the detective piece, I was looking for a structure, which I wouldn't necessarily be looking for now as
Yeah.
the culprit, and that would be fulfilling the narrative from probably the previous provider, and we'd all be in line with it's the structure. And so, if the structure doesn't change or get better, then I'm not going to change or get better. And maybe I see imaging, and so everything from my conversation with the patient to how I handle the narrative, whether I need to adjust it or make it appropriate, and then who makes the decision about the course of treatment, and then how we treat. I mean, all that for me has changed, and I'm happy to say that. I mean, and that's that's one of the challenges as we move forward, maybe in this conversation, I think as an educator, is to, understand that when you're teaching clinicians, it doesn't matter what field you're in, you're not teaching them what to learn. You're teaching them how to learn because they're going to continue to learn and do different things. I tell my students, you better not be doing what I taught you 5 years from now because those things will evolve and change. You can't just be rooted in those things and stick to your guns. Now, some things maybe, but man, there's so much that changes and evolves so quickly that we need to be adaptive.
Yeah. It's we always see that what we do clinically is about 10 to 15 years ahead of the research, right? We do things, we're experimenting on clients, we're learning new techniques, we have different theories and ideas, and we're like, well, this is seemingly kind of working, so I wonder what's going on there. And then 10, 15 years later, a research article comes out or someone's done some kind of randomized control trial, and they're like, hey, this works and this does this. I'm like, yeah, no, we know that's what we thought 15 years ago, but we're on something else now. Like,
Right, right.
right? It's so funny how, research, and, we lean on research to validate what we do. But even some of the, having our working from first principles of anatomy, physiology, neurology, chemistry, physics, once we have this understanding, it's easier to build that knowledge. How, you said teaching your students how to learn. What does that look like in the DPT program? How have you fostered that and encouraged that, as opposed to, I'm in Canada and they're still teaching us what to learn, and everyone's kind of spoon fed, and you read the textbooks, you apply it in labs, and then you go on, and then you go do it in practice. But again, I'm 20 years out, and I go into labs and they're still teaching the same things that I've learned. I was like, I think things have evolved a little bit past this. So how do you go about in your program to teach students how to learn? What are the tactics, techniques,
Yeah.
or strategies?
And I'd say I don't think the U.S. is any further ahead than what you're describing in
Oh,
Canada.
okay.
I,
Oh, good.
I, I think it's a matter of educators being bold enough to push that, because I think oftentimes what educators see is that the low bar of passing the board exam is what we need to do. So let's teach to what needs to be known for the board exam and maybe not sort of the how to learn aspect of it. So I think it starts with having a place in the curriculum to be able to have those conversations, right? So whatever area you're practicing in, hopefully you're not, practicing or teaching in a silo, that you're kind of bringing things together. So in those courses, but presenting cases after foundational knowledge has been acquired. So they've gone through, they know how to do a fundamental musculoskeletal exam, pick out red flags, identify, yes, this is a musculoskeletal problem. Yes, I believe this patient has, something going on with their shoulder, and I think it falls within this realm. Okay, so you know all that. Now, let's present you with a real world scenario. And the way I go about it is I pull patients, and I take a little bit of liberty and kind of, adapting a little bit, but these would all be patients that I've seen as a young clinician
Mhm.
and that I would treat completely different. So I tell them up front, these are some of my mistakes as a clinician. I'm going to talk you through these cases. I'm going to present these cases, let you work through them, see where you end up, and then talk about how I did it as a clinician. Maybe that wasn't the best way, but talking through the thought process. So
Mhm.
at each step, stepping back, sort of putting on the, on the whiteboard or the computer, whatever it is, about, what are you taking away? What things have you seen? And having that dialogue. But that all comes from prior coursework that allows learners to be comfortable with putting things out there that they may not be sure is the right answer or it's
Mhm.
correct, and getting past all that. So you have to do early work in your other classes to create an environment where students feel comfortable having these conversations about things that aren't normally talked about in that way. We don't usually, talk through cases. No, this is the right way to do it. This is what you need to pick up on your subjective. This is what you need to pick up on your objective, and this is what you need to do for them. But
Right.
letting them work through it and have that conversation and have discourse and dialogue and know that that's okay. That there is no right answer. That best is ultimately oftentimes the enemy of better. And we can get in our own ways by trying to create this sort of, ideal scenario on how we evaluate and treat patients when there's multiple ways to do that.
Right.
And my sort of my prime example is I have two cases back to back where the subjective is completely different,
Yep.
but the objective information is almost identical.
Mm.
And they should be treating them completely different because
Right.
you're treating your objective findings in the context of your subjective, in the context of the person in front of you,
Right.
not what necessarily their presentation is objectively. And that helps them to understand, wow, you're right. Like that's, totally different because we're taking the person into consideration overall and not
Right.
just what we find. So I think there's all kinds of creative ways to do that.
Yeah.
And there's no one right way, but I think it has to be intentional, it has to be thoughtful, and it has to be built up in a curriculum to be able to have a space to have those conversations that are meaningful and centered around how you learn and how you work through something, not just this is it, this is what you do.
Are there any specific courses that your university, your program teaches kind of as precursors to kind of teach some of these skills? Like, is there, like, for example, I mean, I think about one of the things for public, if you're going to do public speaking, um, practice stand up comedy, like writing jokes,
Right,
right?
right.
Because,
Yeah, yeah.
like they're amazing storytellers and they keep the audience engaged, right? And laughing. And there's punchlines. You look at certain performers and they do this 10-minute bit and you're engaged. And then all of a sudden the punchline at the end, right? Dave Chappelle's amazing for that.
Yeah.
Like, or do you take concepts and then pepper them into the program? How do you go
I
about
think
that?
it's more the latter. I think there's
Yeah.
threads, that are
Okay.
kind of, as you said, peppered through there. Um, but I would say ultimately too that a lot of the onus as you're talking about this is on the faculty too, right? Being able to, again, create that environment and be that, in a sense, sometimes a storyteller, being able to allow the conversation in the classroom to go where the students take it.
Yeah.
And not just because I've got these PowerPoints, I need to get through these PowerPoints and talk about what's on my slides. No, 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 no. I was fortunate enough to be trained through a faculty residency for 2 years to kind of help develop me as a faculty member and learn to teach. And that was one of the best things for me is to develop my own teaching style and learn from people outside of the field and health sciences, just about how to deliver information that's impactful and memorable and how to engage in these conversations. And that's been huge for me in my ability to do some of these things that we're talking about.
So, I mean, you've taught in both traditional and now hybrid DPT programs. What would you say the biggest differences are? Or let's go with like, pros, cons, or advantages or
Mhm.
disadvantages.
Yeah, I think there's, a lot on both sides and the hybrid of the online piece is relatively new. Relatively, right? I mean, it's been around for a while, but relatively speaking, I think, for guys like me who are very traditional and kind of rooted in different things, I like history. I like the academic experience. I like to be able to walk around campus and see
Mm-hmm.
people and be connected physically to things. And so,
Yeah.
for someone like me, it's challenging. For students, I think if they had an undergrad experience like similar to that,
Yeah.
it's really based on, I would say, kind of past experiences and maybe interpretations of what you think about some of these things. Some people are inherently biased that, hybrid education isn't the way to go, and some people are inherently biased that hybrid education is the way to go. It's
Right.
the way we're headed.
Yeah.
And so I think, it's hard sometimes to put those things aside. I think for hybrid education, there's a lot of pros where, you can engage in different ways. You can sort of reach out to a different demographic of individuals who may not, for whatever reason, be able to attend traditional in-person schooling, do it on their own time, do it at their leisure. So there's some draw to that, right? I think there's some benefit to that. I think there's challenge is in the fact that, it isn't that face to face, and we're talking about in this case, a hands-on profession. And so, you have these immersive labs, and are you making sure that you're preparing them well enough to get the most out of those experiences with immersive labs? And how do you convey some of those intangible pieces over a hybrid environment? Sure,
Yeah.
it's possible, but are your faculty and staff trained to know how to go about that in the best way? Because, and you could ask the same thing in traditional settings, right? If you
Sure.
if you have a clinician who comes right out of clinic, or a PhD candidate who comes right out of doing bench research, neither of them have had training in how to teach or academia,
Right.
right? And so it doesn't matter which environment you throw them in, but I think it's appropriate to understand that there are different needs for students and different needs for faculty in both of those environments, and there should be appropriate levels of training and support for both to go through that.
Is there, so with your program, is it strictly now a hybrid, or is there an option for students to do kind of the traditional way?
It's hybrid.
Yeah,
Yeah.
strictly hybrid. Yeah.
Mhm.
Yeah. So, everything evolving forward, technology, from virtual to in person, AI is coming in. That's a big hot topic of discussion. Where do you see that fits into our profession with regards to AI and how we could
Ah,
either integrate, or I know it's
yeah, I know. I'm a late adopter, and I already kind of divulged my old manness, and I'll own that. But yeah, I have a hard time with it. I see the value and I see where it
sure.
can be useful, but I think in the appropriate way, and both from a learner and from a faculty standpoint, right? And from a professional standpoint, what it means for us as a profession moving forward, and how we may or may not use it, right? We saw what the
Mhm.
first robotic surgery being performed here recently, and and how it was trained, like surgeons are trained in med school and this and that and
Yeah.
algorithms, and it's just, but then you see, the physicians put out, hey, but as a physician, I know when that patient reaches for that door to leave and turns around and says, I've got one more thing to tell you. And
Hmm.
from their experience, they know that that one more thing they have to tell them is typically the thing that they've waited the whole visit to tell them, that actually
Yes.
has meaning and benefit. And they said, you're not going to get that
Yeah.
with something that isn't the human interaction there. And so
Yeah.
for me, I'm an emotional kind of a heart kind of guy. And so I feel like those connections can be lost. From an AI perspective, I think what we have the potential to miss out on is the learning that happens through processes that
Yeah.
we allow AI to do. I think there's value and there's lessons to be learned in trying and failing, trying and failing, trying and failing,
Yeah.
and some of those can be bypassed by using AI.
Yeah. For
But
sure.
there's also some great benefits
Yeah.
to using AI. But I'm admittedly not a huge user of that currently, and I don't know that I will. Everybody's, well, you're going to be forced to do it because it's the way of the future, and that's great.
Yeah.
But yeah, I still write
Yeah.
on pen and paper, so that's.
I've been approached on LinkedIn for my opinion on kind of these postural analysis diagnoses and movement analysis. And the posture program, I say, well, here's the problem with posture. It's a physical representation of both the internal and external inputs. So it's just a snapshot of, is the body protecting something? Is it guarding something? Is there atrophy? Like, it's not telling you anything. It's just giving you a snapshot. And, until you figure out why the posture of why the nervous system's organizing in that particular way, nothing's going to change with it unless you start applying the right, we'll say, inputs to the right areas to create the changes in the physical body. And then the nervous system starts to reorganize and the posture changes. So I said, you can't create exercises from posture analysis. It doesn't make sense because you don't know why they're standing that way or why those things are occurring. It's the same thing with movement. Well, we're doing squat analysis. I'm like, you don't know why they're shifting. Is it a hip impingement on the left? Is it an ankle restriction on the right? Is it a core rotary trunk? Is it a nerve tension from the neck? Like, you don't know. And then you're just going to be throwing random exercises. So this is where I said, look, posture, movement, gait, those are all great as outputs, right? To see what's changed. but you need to find those linchpins. You need to reorganize the system, treat the right areas, and then watch them squat again. Look at their posture and watch them walk. Did something change for the better? Great. We probably did something right. But to try and coach them to walk differently or to squat differently or just to stand it doesn't work.
Yeah.
So, I look at it as we integrate it. It's going to give us another kind of feedback loop to know if we're effective through movement, through posture, through gait analysis, what have you. But to make a diagnosis from a snapshot of how someone's moving, because you can have 10 people doing this kind of lateral shift with a squat for 10 different reasons. You
Yeah.
don't know why. So I was like, you still got to break out the pieces. You still got to prioritize the structure, look at the neurology, look at top-down control, look at rolling patterns, crawling patterns, like look at some of these fundamental patterns. Maybe those are broken and disorganized. That's why they're squatting and running weird. So, it's interesting. People are just like, oh, it's going to take, I said, in the healthcare field where social interaction and psychology is such a huge component, because people come in with these mental barriers. Well, my doctor says I have degenerative disc disease. Great. You have gray hair of the back. So do I. I don't care. Like, let's look at your function. Let's look at what you can do. Like, why are we getting fixed on this? It's so silly. And I think there's going to be a higher value for what we do because as everybody ages, because of that social one-on-one human interaction that people are going to crave. And yeah, like AI it can diagnose, you can put in your symptoms in here, it might spit out some stuff on the back end, but you still don't know why. Everyone's so unique and everyone's coming with their own backgrounds. And like you said, that last thing, they turn around and say, oh, it's this. Like you gave that case study, you gave exact same objectives, different subjective history. Well, over here we have a 34-year-old mom with 3 kids who isn't sleeping and they have back pain. And then you have the baseball player, who's, throwing 100 plus pitches a game and they have low back pain. Well, what are we going to do? Not the same things. Mom, we're going to work on stress management and sleep. Baseball player, we might need to do some rotary stability stuff over here. Like, who knows? But you don't know. But, we're integrating AI machines from Switzerland, and we'll be one of the first in North America. And it's just going to give us more data to know if we're on the right track. It's going to measure leg length, or not leg length, but leg power, endurance, tension. It's like this fancy leg press machine. It uses,
nice.
It gamifies all the rehab, and it uses pneumatic pressure. So you go through all the tests, and it makes this massive data flower. I went to Switzerland and I played on it. I thought it was a big fancy leg press machine. I'm like, oh, this is going to be stupid. And then I'm playing on it. I'm like, and it picked up my left leg could only hold 20% tension in my left. I'm like, oh, okay. And then it designed all the games around it. So then it started to look at my deficiency in my left leg, and it started to grade downhill skiing and Formula One racing and like bowling. And it's biasing specific angles of weakness on my left leg. And I got off this thing. I'm like, this is amazing. And then they have an upper body one too, where it's like
that's so cool.
Yeah. So we're using that, and then people can just jump on it, log in, and then the AI just goes to the next level of the game. And then what we can do with that data now is with the movement coaches, oh, you can't hang on to tension on that left leg. We need to do more isometric work. Or you're losing power or proprioception at 45 degrees on your right leg. Oh, we need to do a little bit of pulsing at 45 degrees to build up proprioception. Or we might need to do some unstable surface training at that angle. And then you go and measure, right? So it can be, it's a trainer, but it's also giving us objective data. So now the surgeons, you can just hit send it to the surgeons for their post-op ACL or their shoulder surgeries. So it's cool because, we're the first in North America bringing it into North America from Switzerland. But it's like, if you don't evolve with it, then we fall behind. And listening to all the experts on AI, they're like, AI is not taking our jobs, but if we don't learn to use it, those who do use it will be taking your jobs.
Right. Yeah. If they can build efficiencies and I mean, that's huge doing that. What you just talked about, that's incredible.
Yeah. So it's going to be super fun, but that's where we kind of see things going. And if people aren't afraid of it, it's just like the Industrial Revolution. You have 100 farmers, and then everyone got scared of the tractor. Well, the
Right.
tractor can do the work of 100 people. Well, what did they do? They just did something else.
Right.
They didn't not work. There's other things for them to do. So,
uh,
but it's the unknown, right? It's that
sure.
psychological component of the unknown is scary. I don't know what that means for me, and am I going to starve? Probably not. But if you just keep moving along with it, and that's where I'm excited for our profession too, because we there's not enough of us, right? Especially
Right.
here in Canada, like 337 schools in the U.S. There's 12 here in Canada, and
Wow.
we only get, let's say, 1,000 new physios a year pop out of school with a growing population. So there's not enough, and but with some of the technology, it can kind of ease off a lot of the loads and documentation and whatnot. But
Yeah, that
you
can be
know,
huge.
yeah, and I wanted to go back. We talked about earlier, kind of one of your driving factors is it comes from relationships and helping others up the mountain. Use this analogy or this great story. How did that mindset evolve where you are today?
Yeah, I think a lot of it obviously has to do with how I was brought up. Um, and seeing examples of my mom always out there helping people, even if, I mean, we always had what we needed, but we didn't have a lot. But she was always willing to give what we had, or more, or time, or that sort of thing to help others. And so, I think every fiber of my being is either woven with like helper or protector sort of mentality. And so, um, that's evolved into my career, I think, because I've surrounded myself with mentors who've been willing to help me, um, and be that example, model that behavior for me and what it looks like in our career as either educators or clinicians or researchers, and how to take that mentality and be that individual for people in those professions. Right? We can all think of examples of how we might help someone who needs help in our lives, but what does that look like in our profession? With the clinician, the researcher, the educator. And so I've had a lot of great examples, models for me as mentors, and my wife's another great model. She's got a huge heart, and she does a lot of things for community and friends and everybody she's around. So, um, I think it's helpful to have that model so you can receive it and then know how to give it back, or at least be aware enough to realize that, oh, I was fortunate enough to receive this kind of mentoring. I was fortunate enough to have somebody help me up the mountain I was climbing. I need to do the same. Not necessarily that I need to either, that I like to, I enjoy it, right? And so, I love spending more time in the valley helping people prepare to climb their mountain than me going up and trying to find a new mountain to climb. It's more enjoyable to watch them on their journey, and help them along their way, versus being out in isolation trying to do your own thing just because you think you need to do the next best thing for yourself. There's not much satisfying in that for me.
I want to take a quick break from today's episode to share something I believe every rehab and performance professional should know about. For years, I saw too many clients go through the same cycle: short-term fixes, temporary relief, and then the same issues coming back again. That's why I built the Advanced Movement Therapist certification. It's not just another course, it's a system that helps you identify the real cause of a client's pain, give them results that actually last, and stand out in a crowded industry. You'll get practical tools and strategies that you can take straight into your sessions so you can help people get better faster. If you're ready to become the go-to clinician in your community, head to amtcertified.ca to learn more. That's amtcertified.ca. Your clients will thank you. What kind of key principles or values do you try and stick to kind of pass down or teach to those that you're helping up the mountain? Do you have a
Yeah.
mantra? Do you have, just a few key things that you kind of stick to so that you can always know, okay, is my behavior matching these key values? Are my actions or my approach to this matching these principles that that I know I can depend on and don't change over time, so that I'm not going astray onto, something that doesn't align.
Yeah, I think that's critical in life and, in and whatever it is to have your sort of what your true north is, right? And that should, in my mind, sort of identified by your core set of values. That's easier said than done. But if you can do that and regularly take an inventory of what that is to you, it makes it easier or maybe sometimes harder to make the right decisions. And know that you're doing the right thing. And so for me, it, I think, if I had to point out a few, would be, kindness, humility, um, not being afraid to see yourself fail and let other people know about your failures and your struggles, and being vulnerable. I think vulnerability is a huge thing, that if you are willing to allow yourself to be vulnerable, other people feel that they can be vulnerable around you and you can make
Mm.
that connection. And I think there's a lot of fear around that. And I think that can be challenging, particularly in professional environments
For
and
sure.
teaching and things like that. And so I think it just comes with humility and just, just being willing to be kind and understanding to where everybody's coming from is different from where you are, right? And I'm constantly reminded of that, or try and be reminded of that, you know, through different, you know, whether it's meditation or prayer, or, my devotions and things, just to kind of ground myself every day. And sometimes it needs to be multiple times a day, just to kind of remind myself of where I came from, where my family came from, what opportunities I've been afforded, and that I need to be giving back. And I think when I try and help others, their value system and their belief system is going to be different than mine. So
Sure.
it's for me, I think, to help them understand what their value system is. And it's okay if it's different than other people around you, but whatever that is, you need to hold true to that. Because it doesn't matter whether you're in PT school or where you're an academician, or whether you're in clinic. Life doesn't care where you're at or what you're doing. It's going to hit you, and sometimes it's going to hit you hard. So to have that sort of life perspective in everything, and just be present, I think is
Mm.
important.
No, that's a good one. Yeah, there's such a stigma with, I don't know if it's more, I'm not, generalizing. Millennials have this fear of failure, they which then creates a lack of action, or at least trying something. um, I don't know if it's just that generation or it's just what I've observed. um, how do you, when you have students with that kind of fear of failure, how do you work around that? How do you get their mindset into, yeah, like, you don't need to be perfect. You don't need a 90 in this program. A 70, you're still getting your degree. But even when I was in school, you'd have these complete academics, and they weren't happy unless they're getting a 90. I'm like, no, no, like, it doesn't matter. Like, the professors just want 46 in, 46 out. They want everybody to pass. They don't really care. So how do you, and then some of them are like, they start to burn out, or they didn't do well in placement because they're too academically focused and not working on EQ because they're too focused on IQ. What kind of strategies, or how do you, if you've had to manage that, or how do you work around that? How do you work with students who have that mindset or fear of failure, and then start to fall apart?
Yeah, that's a tough one. And I think there's a few strategies that I've been a part of, at different places, that may or may not be useful. But I think from the front end in admissions is trying to identify those individuals who aren't either afraid to talk about their failures and sort of what life experiences they've had. So through the admissions process, sort of understanding, or maybe looking for individuals who have a history of failing and then prevailing, sort of being able to overcome those failures and move forward, from that aspect. And then, like you said, a lot of the conversations are around, hey, you know what, your competitive phase is over, right? If it was undergrad training to get into PT school, like, that's over. You're here, right? We're all here. It doesn't matter, like you said, whether you get a 75, 80, 90 on this exam. The idea is that we want you to understand the knowledge and be able to apply it to the next part of the curriculum. So if you got a 90 on it, but you can't bring that forward from your foundational concepts and be able to apply your understanding of physiology and the nervous system into musculoskeletal, then it didn't serve you
Mhm.
well.
Yeah.
And then I think, as I mentioned before, I'm also not afraid to make myself vulnerable in the classroom and talk about my mistakes, talk about, how I, as a young clinician, maybe didn't handle these situations the best, and make those my case examples, and let them work through them and understand that, none of us are perfect. And I also, you know, one of my little things I like to do before each class is, I tell them it's kind of like, if you're an athlete or a coach, you review film afterwards. I said, I always go through film afterwards in my head after class,
Yeah.
what I could have done better, what were my takeaways. And so before class, I talk about, some of the things I thought I could have done better, or some of the things I missed out on opportunities, or, points I wanted to make that I didn't, or, this, that, and the other thing, to let them know that those things are actually okay. You can't be successful at anything without having failed. Like, I don't know how that's possible, but somehow, I don't know through if it's through past experiences where they've never been involved in something enough that put them at risk to
Yeah.
fail because it was
Yeah.
a safe thing to do, right?
Yeah.
Maybe they were at the top of their class or the top of their team or this or that, and everything they did they were successful at. So
Yeah.
maybe this is their first failure and they don't know how to handle it. Well, then that's
Yeah.
my job to help coach them through that, and to let them know it's okay. And so that's where I think developing relationships with students is also important. So you kind of know a little bit about their history, through all that, and where they are on that spectrum. Because just like patients, all the students are different. So you can't have the same way to sort of work on this aspect with all your students, because all your students come from a different mindset, from
Yeah.
a different place, from a different background. And so how do they handle failure? Well, ask them.
It's again coming back to the DPT program because you have a lot less time one on one, right? You've got small blocks. How do you go about that with how do you coach the students because a lot of their lectures are online and then you see them for a 3 week block. How do you navigate that? Because it's not like you're seeing them every single day for the next 2 years in
Right.
every single class, you know, outside of class, on campus to kind of get those little touch points to know, hey, I noticed you struggle. Like I almost failed physio school with from
Yeah.
neurophys. I got called
You and me
up.
both.
I got called up to one of my professors is like, yeah, so me and my buddy Arvin, you guys got a 58 on the midterm. We're like, yep. Okay, so how can we how can we best support you so you don't flunk out of this program? And we just like it was that first semester was hey, we had neuroanatomy, we had anatomy, like it was just a very, very, very heavy first semester. And we just stuck our nose in the books and went to the library every single day until we had our whole notes memorized. Um, I it'd be tough to do that because the professor can grab you that day and tell you, come up, hey, let's have a conversation. You've got a 3 week window, or you're not seeing them on a regular basis because maybe they're pre-recorded or they're it's a live session, but you've got how many 120 kids on your Zoom screen. They're not gonna how do you pick them out of the audience because you can't see their body language, you can't see them like slumping down in their chairs or hiding, or just their energy. You can't feel their energy through a screen regardless of
Yeah.
whether you're talking to them or not. You see somebody, you feel it because of that magnetic field, because of that lack of coherence. You talked about, you treat from the heart. What do we know about the heart? Well, it emits a magnetic field, right? Of like 4 foot radius, 8 foot diameter. And when you have two people coming into their magnetic fields, their hearts actually start to sync up because of that coherence. You start connecting or jiving with that person. It's because you're in coherence, and it's subconscious and it's at an energetic level, but you can't do that on a screen. And how do you do that in a program where you're only with these kids 3 weeks of the year or 3 weeks a semester to to do labs, to interact that way?
Yeah, I think in my mind, for me personally, I think that's one of the biggest challenges,
Mm.
with hybrid education. And admittedly, it's because I think that's one of the things that I draw on, is that interaction, as we've talked about before. So um, to help meet some of those challenges, and we have director of student affairs who kind of oversees kind of all that, and then we have different. We have a coaching model, where each faculty has a number of different, so different than advisees, but kind of similar, and regular touch points. But much more regular touch points where we're connecting with those individuals and trying to have those difficult conversations, early identification with maybe people who are struggling, because there is a potential, a greater potential, I think, just like there is in traditional school too, but for people to kind of hide a little bit. They
Yeah.
might be struggling, they might kind of hide in the back of the classroom in a traditional setting, or they, you might not be able to even pick it up that much in a hybrid setting until you get that first set of scores or whatnot.
Right.
And so I think, identifying them early on, reaching out,
Okay.
creating touch points, and then developing a plan with them that's meaningful yet attainable
Mm.
for them. So yeah, I think there's still work to be done in that area and how we make that. And I personally don't think there's any substitute for that personal one-on-one connection.
Yeah. What else would you say we're getting wrong in PT and education across North America?
Boy, yeah. No, there's a lot of great things, and
Yeah.
I'm one of the things I'm working on personally is being less critical overall. But as a
Mm.
researcher, it's kind of hard for me, as an
Yeah.
editor and a reviewer. It's like a lot of my day is taken up by trying to pick out little things that could be better, or
Right.
this methodology was wrong. So I trying to be less critical. So
We're,
thanks for the question. Um, no, but I think I think some of that boldness that we talked about before might be missing a little bit
mm,
in the PT education, to be willing to put those things out there that maybe don't, you know, match up with an outdated computer-based board exam, but that we know are going to help our students be better clinicians, either today or 5 years down the road. And in, oftentimes shortened curriculum, or, trying to get the most out of it, eh, how do you do both, right? How do you provide those things that I personally think they need to know beyond the board exam versus what they need for the board exam? And oftentimes those things don't jive.
yeah.
So it's, how do you teach them something that's outdated that actually can do your patients harm in a roundabout way versus teaching them what you know based on the three pillars of evidence-based practice that are going to be the most beneficial for their patients. So I think some of that boldness is missing. I think some training is missing in
Yeah.
education. To be honest with you, like I talked about, whether you're PhD trained or you're coming out of the clinic, either way, you enter academia, and if nobody teaches you how to teach or how to write a test, or do those things that need to be done in order to provide those students with a quality education, that can be challenging. And so I think there's a lot of that, and we see more and more needs for PT. So there's going to be more PT programs, and
Yeah.
so you're going to need more PT faculty, and
Right.
it just
Yeah.
so there's an ever growing need for that. So I think some of that boldness and some of the willingness to let go of your own biases and things that you may like to hang on to as an individual, and being willing to change, that comes across a lot too, um, which, yeah, can be detrimental.
Yeah. I mean, going back to your being very picky, we can call it picky, or we can say it's just being a little bit more precise. When we're working in our clinic and we're doing mentorship every week, I tell them, like, look, you're doing muscle testing. It matters where your hands go, because you can't touch the muscle that you're testing because it will facilitate it at a sensory motor cortex. Stabilize someplace else. I said, and it also matters where you place your hand down the kinetic chain, because if I'm testing glute medius and I have my hand on the foot, well, now I'm incorporating the peroneals. Well, that can upregulate because that might be compensating and facilitating. So you have to make sure we do this, what's called kinetic chain muscle testing. If if you have your hand in the wrong spot, you're going to get, you know, less optimal results. You might get a false positive, you might get a false negative. Maybe the foot is inhibiting the hip. You don't know. But be picky, and especially with your exercises and your movement prescription, be precise. Clients will come in, do your dead bugs, do your planks. I'm like, have them do it their way, and then watch how many times they get it wrong. They're not setting the breath. The ribs aren't coming down. There's no posterior pelvic tilt. Their neck is too much. Like, there's so many things that they're doing that makes it not an ideal exercise, right? Something deadlift, squat, whatever it is. Said be picky, right? But the pickiness will add to precision. Now, going back to, can we be picky about everything? Probably not. It's probably like an 80-20 rule. Like if they're doing 80% right, you're still going to get the benefits.
Right, right.
They're probably still going to get the positive adaptive changes as long as you're not causing pain and compensation and they're feeling the wrong muscles. They'll probably be fine. When you get into higher elite athletes, you have to be more precise with their positioning
Okay.
and their posture to get the pattern, to get the power. It's because that can drive you mad because they will never, nobody will do it the way exactly you want to do it. And you have to be okay with that. And I was like, look, if your clients are getting results, that's all they care. That's all they care. Who cares?
Right.
If they're stuck, okay, now we have to kind of be a little bit picky, or maybe we're in the wrong area. But 80-20%, 80-20 rule for most clients, most of the time, what people need is just 80% of the stuff they're not doing. And it's very general. And then we can kind of tailor it to them more specifically with their imbalances. But yeah, if you were, okay, so if you were given the title of king of PT world, what is one thing you would change, or one one thing you would either change, or one thing you would add for the best success of new grads coming into the clinical world?
Oh, well, first thing I'd do is take that title away from myself because that's awful. Um, no, but if I were given the purview to change anything, for a new grad coming out, I think it would be a mindset of, give yourself grace and give your patients and everybody you interact with grace. I think oftentimes they're too hard on themselves. They expect perfection. They expect the most, and there's nothing wrong with expecting the most out of other people, but you got to give yourself a break at some point in time. And recognize that you're human. You're not going to get it right all the time, and you're not going to help everybody all the time. And that's okay. I mean, it's part of the game, and I think that can weigh heavy on a lot of new and older clinicians, right? And um, I'm not saying don't have that mindset of trying to help everybody, but know that oftentimes we can't help everybody to the degree we'd like to. So I think a little bit of grace goes a long way.
Yeah, I think saying I don't know, but I will
Yeah.
find you that's such a hard thing because I mean, for me, it was. I think the newer grads coming out, they're okay with saying, I don't know, after they've tried a few things. Sometimes I think they say, I don't know too soon, rather than like trial and error, like try some stuff. Like you're not going to
Right,
kill
right.
them, you're not going to hurt
Right,
them.
right, yeah. Yeah.
Try some things rather than, because then you've lost all confidence because you haven't tried anything or you haven't tried enough. Then the patient's like, well, why did I come here in the first place? We haven't even tried, you know, anything. Um, but yeah, I mean, as a veteran clinician, you've tried a bunch of things, or you just know, like, my tool set is not going to help you. I need to refer you to somebody else.
Right.
And even that, you're still the expert. You're still kind of the quarterback. And like, I'm going to touch base. I'm going to get you in contact with this osteopath or this chiropractor or this TCM practitioner to really work on this part of your system that I think is your linchpin that's kind of shutting stuff down. And then, once you work with them, come back and see me, or let's try something else. But that's building your network around you as well, because, as you said earlier, it's, if you have those around you to build that team of superhero clinicians from many different mindsets, perspectives, and tool sets, it's just going to make you better as the expert in the area as well. So I want to kind of lean into, what are you kind of doing personally to stay sharp, stay relevant, and fulfilled in your career as of lately? What are you into?
Yeah, I think for me, it's being much more mindful of when I set out on a project. I might be really super excited about the project or the team I'm working with or things like that, but really stepping back and saying, what's the potential impact for both clinicians and patients? Is this just something to continue a line of work? Is this just something to get another publication out there? What's, the real potential outcome and the impact, and how can I have a better opportunity to make that more meaningful from the onset. And sometimes it might mean, changing the way the project is designed altogether. And so I think I used to be like really excited about any project I could, do and, get involved in and work on, but now I'm much more selective and thoughtful, even if that means, I'm not publishing as much or I'm not, doing as much. It's really truly sort of at this point the quality versus the quantity. And that can be challenging because I see, peers and mentors I look up to, doing all those things, and that's great. But for me, I think it's I'm trying to look more more at the impact.
Nice. So what's one thing that is making you, that you're working on, that's making you uncomfortable, or one thing that you're learning right now that's making you uncomfortable in a good way, of course?
Yeah, yeah. I think something that's hard for me that I'm trying to adapt to a little bit better is like the impact that potentially social media could have with research and reaching a larger audience.
Yeah.
Because there's a lot of not so great stuff out there, but then there's also, people doing really great things and getting messages out there to a larger, broader audience, and doing it in a really professional and meaningful way. And so I'm trying to, that's uncomfortable for me because I'm not a big user of social media. And so I'm trying to, every time I dip my toe in, I quickly take it out. And so, but I've started to develop some different relationships in different areas from researchers and things through that, and so it's been fruitful. But I also recognize that sometimes in order to get things out there a little bit quicker to a larger audience, appropriately, that might be, as I'm talking about the impact piece and how work can be more impactful and reach a larger audience and, help evoke change. That might be one way that, just because I'm uncomfortable with it, doesn't mean that it can't be effective if used appropriately.
Okay. One last thing. If you could give your younger self one rule for longevity in this field, what would it be?
Take your time.
Ooh.
Yeah, I think we come out of the gate and we wanna run, right? We've
Yeah.
been in the barn for so long, somebody opens that gate and we just want to show people how fast we are. Like, we just want to run and just go at it. And that's great for a while, but you got to realize, like, and it's really cliche to say it's a marathon, not a sprint, but there's a ton of truth to that. So, you know, be as efficient as you can in the things you're doing that are meaningful before you pick up something else. So be the best sort of, version of that you can be before you spread yourself too thin doing a million different things and not being good at any of them. So really develop your skill set in one area before going into another piece. I see people trying to add all these letters to the back of their name real quick and do all these wonderful, cool things that they think on the outside look good, but that really doesn't matter. Think more about what's going to be meaningful to you and your patient going forward. Um, and I think you just slow down, take your time, be efficient, be the best version of you that you can be in that particular thing before moving forward.
Perfect. Ladies and gentlemen, Dr. Paul Salamh. Where can everybody find you, Dr. Paul?
Uh, in Indiana, if you really want to come see me, but
Well,
yeah,
let's
I
put your
mean,
address in the show
yeah,
notes and people can show up to your house and
there you go.
hang
Yeah,
out for a
yeah.
bit.
No, I respond really quickly to email
Email.
usually.
Okay. We'll put that in
Yeah,
the show
so
notes.
shoot me an email. I'm always happy to have conversations around mentoring, development, research, education, whatever I can help you with.
That's great. Well, I appreciate your time. I appreciate you and all the work you're doing. And I'd like to do hopefully a part two because I still have a long list
Cool.
of questions I want to get to. And
Awesome.
yeah, we'll get to that. Awesome. Thanks for
Sounds
coming,
good.
Paul.
I appreciate it, but thanks for having me.
Thanks for listening to this episode of Staying Relevant. If you enjoyed it, check out the AMT certification at amtcertified.ca, where we help clinicians and coaches get better results faster. Don't forget to subscribe for more episodes and share this with a coach, clinician, or athlete who needs to hear it. Until next time, keep learning, keep growing, and keep staying relevant.